But the webinar for this afternoon is intended to be able to look at our transition, how we move from first line to second line and to third line. I'd like to be able to say my apologies. I'm not using the FPD slides. I'm using slides that I presented elsewhere. If I can go straight, perhaps that as a way of a background, switching from second line, from first line to second line is typically done with the assistance with doctors that are experienced in HIV medicine. That's the first and foremost point that I would like to point out. Secondly, there have been, what's happening here? There have been WHO early warning indicators around the guidelines on how to switch from first line to second line. I want to switch it off completely. Yes. So these early warning indicators have, I think, about 5 or so domains. The domains talk about, first and foremost, the number of patients that are on correct regimens, meaning patients that are properly on correct regimens. Secondly, is the proportion of patients that are on the first line, and I want to be able to dwell perhaps on that one. And the WHO stipulates that patients who are on the first line should constitute about 95% of our patients. And here we're referring to our NEMAT patients. And we have been training quite a good number of NEMAT candidates throughout the whole country. And these NEMAT patients actually should be managed on first line. And for how long can patients remain on the first line? A good number of them can remain on first line for as long as they are adherent to their medication and the viral load is suppressed. And this, we've seen that patients can remain on the first line for more than 20 years. I have anecdotal evidence from my practice of patients who have been on treatment for the past 25 years or so. Obviously, with changes of the NRTI backbone here and there over years, from T4T to AZT, from AZT to TDF, and we have seen those patients remaining and currently is transformed to the TLD regimen and remaining on that first line. So those are some of the principles that I would like to be able to talk about. First, that most of our patients should remain on the first line, and it's one of the indicators of early warning indicators. We should have more than 95%. So when we're talking about second line and third line patients, what we're referring to is about patients who are failing their regimens. So let's consider the first indication from switching from first line to second line. The first indication for switching from first line to second line would be patients who are failing NNRTI-based regimens. This is your favorite TEE regimens or the TEN regimen, which is tenofovir, efavirenz, and nevirapine. Rarely do we have patients on this regimen these days. However, those patients need to demonstrate a viral load above 1,000 copies on more than 2 occasions after you have instituted adherence measures, what we would call your ABCD interventions. So your NNRTI-based regimen is your first line. In this particular instance, when you're shifting your patient from the first line to the second line, you do not need to move from the first line without looking at the viral load. The viral load typically is important, and you want to be able to institute the ABCD measures. By ABCD measures, we're talking about adherence. We're talking about bugs, which are infections, typically TB. We're talking about a correct dose, and I want to throw in as well the concept of cancer as well. Increasingly, we are seeing quite a good number of patients with CA cervix and also colorectal CA falling into the category. And then D, you can put your drug-to-drug interactions as your guide to be able to really intervene before you move on to second line. And last measure, we're looking at resistance, which is represented by an E. Let me present a case study of a patient that I have from my practice. I'll call this patient, for the sake of privacy and confidentiality, Mr. MK, who is a 52-year-old businessman in Johannesburg. His main presenting complaints were lassitude, not gaining weight, insomnia, no fever, no night sweats for the past 2 months. Of note, we picked up that his BMI was 20 kilograms per square meter. And on examination, the significant finding there was a large inguinal lymphadenopathy. He had been HIV positive since 2012 and stopped out and reinitiated on TE since 3 months ago. And this is as of 2020 last year. Regarding TB, there were no overt night sweats, no cough, but the patient was looking unwell. And as clinicians, we go with the clinical picture that patients present to us. At baseline, the reinitiation, we did a viral load, and this viral load came up to about 8,000 copies per mil. And 1 month later, a patient had a viral load of 23,000. If you look at this case scenario, you'll be have all the indications of actually switching this patient from first line to second line. Remember, this patient is on TEE, as you can see above. He had no non-communicable diseases, and there was no evidence of STIs. Mentally, he had features of anxiety, largely because there was no business activity during the COVID-19 restriction at level 5, 2020. And one would ask the questions, how do you manage this case? So let's see how we apply the ABCDE intervention. You'll be able to look at adherence. Mr. MK was perfectly adhering to his medication. Then the next thing, in a stepwise fashion, we look for bugs. He had a large inguinal lymphadenopathy measuring about 10 centimeters in diameter. Across the widest diameter, it was 10 centimeters. So what did we do in this particular case? Based on that large inguinal node, I went ahead and did a biopsy. And I want to illustrate to the participants who are here the pathology report, which I'm flighting up here, show that there was a portion of tissue lymphadenopathy measuring by 45 by 20 by 10 millimeters. Quite big, so it was more than about 4.5 centimeters if you're looking at the size that finally arrived at the lab. The conclusion of this pathology report was that this patient had a large necrotizing granulomatous lymphadenopathy secondary to by myobacterial infection consistent with active TB. So there was no evidence of neoplasia or cancer in this patient. So clearly, when we do a proper clinical examination of our patients, where we're looking at the A standing for adherence, we move on to B. In this particular case, we're able to pick up the bug. The bug in this case being active TB. Now let's go back to the case. You can see there there are no overt signs of TB, but as a clinician, as soon as you see a BMI being less than 18.5, that must alert you. In this particular case, the BMI was sitting at around 20. There were no overt night sweats, no cough, and the patient was looking unwell. We started this patient on TB treatment, and 3 months later, when we checked his CD4 count and the viral load, these were the readings. The CD4 count had not gone up significantly. It had just crept up to about 335. The viral load had actually well suppressed in less than 20 copies without the need for moving to second line. So we demonstrate here that it's important to be able to check for bugs before you move on to second line. Now let's move on to see the other regions, and here I'll skip some of the switching regimens and I'll go straight to the switching because of virological failure. So we're saying any viral load above 50 copies is an early warning indicator of virological failure, and we want to be able to treat this as an emergency. That's the first and foremost thing, because our goal of therapy and our goal of success of ART is to be able to keep that viral load well suppressed. So how do we go about with it? We use the A, B, C, D that I've referred to. Then, in a stepwise fashion, you then go on and check for the tolerability of the ART regimens. We have seen that certain medications, patients find it very difficult to tolerate the medication. So that's the first thing that you want to be able to look at. TEE, as you would know, the efavirenz component is associated with CNS side effects. These CNS side effects can be worrisome and can actually be a cause of poor adherence. Then you go on and review the history and examination or the clinical picture of the patient. Just go through the notes carefully, and that's why we're saying the proper recording of all pertinent clinical scenarios or clinical events in a patient's journey are extremely important. You'll be able to look at the previous viral loads, you look at the CD4 trends, and you want to be able to look at pre-existing resistance data if it's indicated. The next principle that we're looking at, as you consider shifting to second line, we're saying basically the regimen should include preferably more than 2 and preferably 3 fully active agents. And these are agents that do not show any uncompromised activity based on the treatment history and also the resistance patterns that you're getting, and perhaps a novel action in the life cycle of the HIV process. We also consider as a principle the hepatitis B surface antigen status of patient before switching to the second line regimen. And here we're saying, as you know, tenofovir and 3-TC or emtricitabine are also known to be active against hepatitis B and also HIV. So there's cross-shared activity across these two infections, which is HIV and hepatitis B. So in moving to second line, you want to be able to suppress the viral load of the HIV, but also you also want to keep the viral load of the hepatitis B well suppressed, because it's been noted that when you don't consider that hepatitis B surface antigen status, and in patients who are positive for hepatitis B, you can get a flare-up, and the patient all of a sudden can develop liver toxicity, and you may wrongly ascribe it to the second line, when in fact it's ascribed to the rebound viral load of the hepatitis B. So it's extremely important to be able to consider that. So let's quickly summarize, and some of you are very familiar with these, and I'll go through them pretty fast. If a patient has been on a TE-based regimen, let's consider the first column. We're saying here, resistance testing is not required. Most patients in this particular group, when they fail their regimen, tend to accumulate NNRTI-based regimens. For the sake of this discussion, I'll pick up just one mutation per group of NRTIs. TDF, together with abacavir, tends to elicit your K65R mutation. Hello? It appears I'm offline. It appears I'm offline here.
We can still hear you, doctor.
You can still hear me, okay? TDF and its cousin abacavir tend to elicit um, a K65R mutation. This type of mutation confers resistance to TDF and abacavir. 3TC and FTC share a parent molecule. The parent molecule is 3TC, and in the presence of resistance, typically there is an M184V mutation. The presence of the M184 mutation actually is a beneficial effect, and you realize that in the first line and second line, and even in the third line, we also still maintain the 3TC in the line. And here we're referring to the M184V mutation. It tends to cause a crippled population, or if you like, a weaker population of the HIV. So we like it in the first line, second line, and third line. Efavirenz and nevirapine, to be specific, as the first generation NNRTIs, they tend to bring in a mutation, and I'll select one common mutation or a signature mutation here, referred to as the K103n mutation. In the presence of that mutation, we tend to have some high-level resistance to efavirenz and nevirapine. And if you're looking at literature, it's been noted that the presence of this mutation actually creates a more fitter and stronger HIV population, and it can actually stimulate mutations to other drugs and other classes of ARVs. So in the presence of virological failure, which would be 2 viral loads above 1,000 copies on 2 occasions, at least 1, 2, or 3 months apart, depending on the category of patients that you're dealing with, you would be able to say there is virological failure. I'm referring to this because you're looking at, in some instances, patients with a viral load of above 1,000 in pregnant women. We typically would change to switch to second line at around 4 weeks. Also would consider switching to a second line in some instances after 2 months. However, usually we talk about 3 months in your patients who are non-pregnant. So we're saying resistance testing is not required in this particular case. We then consider the hepatitis B surface antigen status. If the hepatitis B status is negative, would simply bring in a completely new regimen consisting of a 2 NRTI backbone that has AZT, 3TC, and would bring in dolutegravir or DTG as our third agent. In clinical practice, you'll see that if we're following the line, that column there, where they say if DTG is not suitable, such circumstances are rare, except in your patients with a gross or severe obesity. You'll want to not use a DTG in those particular case. The advanced trial, which showed that DTG was associated with a significant increase in the weight of patients that were studied on ART. So in that particular case where you find, for instance, the BMI is significantly higher than usual, you then opt to go with AZT, 3TC, and lopinavir without the DTG. So you'd actually move from DTG to a PI-based regimen. And here we're looking at lopinavir and ritonavir. In my practice, I've seen quite often than not that the best choice that tends to fit in very well. Most patients tend to find lopinavir or Aluvia as an intolerable containing regimen because the pills are big and the pill load is high. I prefer to go with atazanavir. Atazanavir being much easier to administer. And if you quickly look at the number of tablets on the AZT, 3TC, and lopinavir combination, easily you're talking about 4 tablets for lopinavir and 2 tablets of the fixed dose combination of AZT and 3TC, making your pill load from a single tablet regimen to a 6-tablet regimen. So that pill load can be reduced if you use atazanavir instead. In your Hep B positive patients, we would actually bring in TDF and 3TC or FTC as your agents that are active against hepatitis B. And then you bring in 2 new agents. This is AZT and DTG. Where DTG is not suitable, and here we're looking at the one major trial, it showed that the TDF plus 3TC and lopinavir combination can actually be used successfully. And some of you may be able to observe that it may appear to be monotherapy, when in fact, it's been shown that at least we have one active NRTI and perhaps a compromised activity of TDF. So let's look at a patient, and here we're seeing currently as we move and transition or start our patients on the TLD-based regimen. TLD requires quite a good number of mutations, and the signature mutations for DTG that I can talk about is the so-called R238K mutation. In the presence of that mutation and other mutations, you accumulating over a period of time, you can have insta-base, you can have DTG resistance. And here it takes all the way up to about 2 years. We have reviewed the literature on DTG, and DTG has been shown to have a high barrier to resistance, meaning it's difficult for ARVs, for HIV to be resistant to DTG, or if you like, it's difficult to break this type of regimen, meaning we should be using this regimen very carefully, TLD, in well-selected cases, meaning our patients who are not on TB treatment, patients who are not diabetic, and perhaps where you need to adjust doses, you need to adjust doses carefully. Now, resistance testing, when you're switching from TLD, first, the patients have to be on their regimen for more than 2 years. Basically, if you should start a patient on ART and the viral load remains above 1,000, you need to continue on that regimen, because it's been shown that a good number of these patients actually will suppress if you do the right thing. What is the right thing? I start off with adherence counseling, and perhaps checking on the bugs. The correct dose is not a big problem with fixed doses. Drug-to-drug interactions for TLD is a very significant issue. Here, the significant drug interactions that we should be can lower the concentrations of DTG would be your rifampicin, it would be your anticonvulsants, and your polyvalent cations such as your calcium, magnesium, zinc, selenium, and iron. You need to be extremely careful, and appropriate advice should be offered to our patients when you start them on a TLD regimen. I typically ask my patients to bring all the medication that they have in their facilities. Or at home. And then I go through the drug-to-drug interactions with them on a case-by-case basis and advise them. Most recently, I can add some new traditional and alternative medicines that potentially can affect the TLD regimen. You should be on the lookout for aloe vera. Aloe vera is an inducer of the cytochrome P40 enzyme system. Also, we have noted that your African potato has also been shown to actually induce the metabolism. And to some extent, if you look at the use of fresh garlic being added to as a calitrin substance or as prevention against flu-like infections, including COVID, patients are consuming lots of garlic. It actually can increase the metabolism or induce the metabolism of DTG. In this particular case, resistance testing when you're shifting from first line to second line is required under expert consultation. And here, what does that mean? And let's perhaps unpack that. It means basically patients who have been exposed to TLD and there was no adjustment of a dose if they were on a rifampicin-based regimen or on an anticonvulsants such as phenobarb, phenytoin, or carbamazepine, those patients would actually require a resistance testing, because you are saying there's a possibility of a pre-existing drug-to-drug interactions which could have influenced the failure of that regimen. So it's on a case-by-case basis where you actually look at this particular case. Otherwise, in most instances, we wouldn't look at on a resistance testing. Again, the hepatitis B status should be considered. So in your patients who move on to second line, if the Hep B is negative, would go onto the PI-based regimen and still retaining AZT. You'll notice that AZT in this particular case has been reserved for second line purposes. Whereas in neonates, AZT is your first line within the first 4 weeks in your underweight and preterm neonates. If the Hep B is positive, you would actually bring in your Truvada or Tenamin in the form of TDF and FTC, and you'd actually simply add lopinavir, which is known to have a high genetic barrier to resistance. So this is our first line, shifting from first line to second line. So to recap, we are starting from an NNRTI-based regimen. So efavirenz will then move on to DTG. If you fail your DTG, you move on to a PI-based regimen, which is lopinavir, ritonavir, easily substituted by atazanavir and ritonavir. Moving to second-line regimens, you have noticed throughout this whole process, AZT, 3TC, lopinavir or atazanavir typically fall into the second line. In all these instances, resistance testing is required, and we note that lopinavir requires at least 6 mutations, particularly in the presence of the L76V mutation. You'd actually require a resistance testing. And if you actually demonstrate the presence of a resistance in that particular case, you then go on and say, this patient actually needs to be moved on to third line. Third line is happening at the National Department of Health, and it happens, and the choice of regimen that we are going to use in the third line will depend on the mutations that we find on the resistance testing. If the Hep B there is no resistance, or if there is no resistance to a PI, there is a study that has shown that, as a matter of fact, you should continue with that regimen, because your patients tend to respond, more than 50% of your patients will actually respond to that PI-based regimen. Right, I'm moving on to the neonatal regimens. And here I want to be able to reflect on how we transition from children and perhaps see how we move on to the second line. So we say, if you're looking at children that are born with a weight of 2.5 kilograms or birth less than 4 weeks of age, and here we're talking about gestational age, meaning preterm babies or underweight babies at 2.5, less than 3 kilograms, we would actually start them on AZT, 3TC, and nevirapine. We'll then wait until they either pick up the weight or the age, meaning above 4 weeks of age and 42 weeks of the gestational age. We'll then be able to say, and the weight above 3 kilograms, will transition these kids to abacavir, 3TC, and lopinavir. Would wait for the weight to be able to go all the way to 20 kilograms. And a very important note there, the transition from the neonatal regimen to the infants and children regimen does not require any viral load suppression. Then, should they gain their weight above 20 kilograms and less than 10 years of age, 2 conditions that have to be met, we then transition to abacavir, 3TC, to DTG. We're almost doing the reverse, what we saw in adults. Typically in adults, we'll start off with a DTG-based regimen to a PI-based regimen. But this time around, we are moving from a PI-based regimen to a DTG-based regimen. This transition from lopinavir to DTG requires that the viral load must be well suppressed in the last 6 months. So viral load must be well suppressed, less than 50 copies. When they attain a weight above 35, remember this is when we're looking at the indications of using TDF, and a weight and an age above 10 years. We then transition them to TLD regimen. Again, we need a viral load that's well suppressed in the last 6 months, and also that ensure that the renal function is okay. We would use, in this particular case, your Schwartz formula, which calculates renal function in children, or what is called the Condon-Barat formula. And we consider an eGFR above 80 mils per minute to be normal in children, as opposed to 50 mils per minute in adults, non-pregnant, and also on ART rather than on PrEP. For PrEP purposes, we consider a normal eGFR to be above 60 mils per minute. For pregnant women, would consider the creatine clearance, the creatine levels of above less than 85 is normal. So you understand that for different category of patients, we use different cutoff values of the eGFR. So for children, for us to transition to children's doses, we need an eGFR above 80 mils per minute, and that's considered to be normal. So let's go on and move on to this, to see how we move on to second line. So what is the principle that we're looking at? If a child is on an NRTI-based regimens, this is a child, like in our old regimens, who have been using abacavir, 3TC, and efavirenz above the age of 3 years, and having a weight above 10 kilograms, as we used to do in the past, you would now need to be able to consider switching them either to a DTG-based regimen or a PI-based regimen based on their weight. If their weight is less than 20 kilograms, you'd actually go to a PI-based regimen because they haven't attained a sufficient weight for you to be able to use DTG. If the weight is above 20 kilograms, you'd actually go to a DTG-based regimen. And if they are on a PI-based regimen, you'd actually switch them onto a DTG-based regimen. That's the sort of requirement. In children where we are switching from an NRTI-based regimen, or we're moving from a PI-based regimen, we're saying resistance testing is required. And so let's see how we go on with that. We say at least one NRTI should be active in this particular regimen. So let's quickly look at the transitioning. First, if a patients are on an NRTI-based regimen, meaning abacavir, 3TC, and efavirenz, and I'm pulling that one easily because that's a very common one. Rarely do we see children on a TEE-based regimen. These are children above 10 years of age and weighing more than 35 kilograms. They could be on that. In that particular case, resistance testing is not required, and we simply consider the weight of the baby, and if it's less than 20 kilograms, we'll transition to a PI-based regimen consisting of AZT, 3TC, and a PI, lopinavir, ritonavir, or a atazanavir tablet form or syrup form. Now, above the weight of 20 kilograms, we would consider a PI-based regimen. Fortunately, the combination of DTG is now available in a fixed dose regimen. So abacavir, 3TC, and DTG is now a fixed dose combination. But here you'd have to have at least one NRTI being active in consultation with a pediatric expert. And if DTG or a DTG regimen is not, if NRTI activity cannot be confirmed, basically most people would say go on and have 2 NRTI as your backbone plus a PI a boosted PR. In a setting where you have had a patient on abacavir, 3TC, and DTG, this is a fixed dose combination. When you're moving to the second line in children, it is recommended that you do a resistance testing. And again, if there's no PI resistance, you simply continue with that regimen because they are telling you they are not adhering or there's something that's happening. And this is where the exploration on drug-to-drug interactions becomes important. And there you can actually continue if there is no PI resistance. In some instances, if you cannot demonstrate NRTI activity, you can actually use a PI-based regimen. In all instances, when you're moving from first line to second line, let's us remember that adherence counseling and adherence issues should be considered. If they've been on a PI-based regimen, meaning possibly AZT3TC and lopinavir, you would say in all these instances, these patients they had required resistance. You then need to be able to refer to the third line committee. And as I said, the choice of regimens and the choice of the cocktail of art regimens that are placed in the third line is typically decided by the third line committee, but consideration is made on the active mutations that are present in that resistant profile. If patients have been on an INSTI-based regimen, and here we're talking about AZT, 3TC, and DDG, we said again, resistance testing is required. If there's no resistance, continue with your DDG-based regimen. And in some instances, this is where you may need to refer to the third line, even if you have not demonstrated any INST resistance. And where there's resistance demonstrated, you'd need to be able to move on to the third line committee. I think I'll come to the end. Safe to say, I want to be able to emphasize some points. When you're doing adherence testing, make sure that your patient is adhering to that particularly failing regimen. They must remain on that regimen for more than a month because there is what's referred to as auto-archiving. HIV under the suboptimal pressure or in a failing regimen will stimulate the mutants. But as soon as you withdraw the failing regimen, the wild type or the original HIV species predominates, and the HIV resistance may not be picked up. If there's PI resistance, in all instances, a patient needs a third line, and third line is decided at national level. If there's no PI resistance, the patient is simply telling you, I need more work on adherence, and this is where the new adherence guidelines that were published in 2016 come in very handy. We need to be able to foster more and more on adherence counseling with our lay counselors, with our community health workers, with our community caregivers. And there's a third line committee that sits at the National Department. In my last interaction, I was told that Dr. Ruth Lancaster was responsible for this, and that's their email address. And they will authorize on a case basis for a third line based on the PI resistance. And the particular study that I was referring to, the NS study showed that if you work on adherence and adherence counseling in a good number of patients who are on PI-based regimens, most patients will actually respond, and there is no need to be able to move to third line. So in summary, as much as we have newer drugs and understanding the newer drugs, as much as we have seen how DTG is going to completely change the picture of administering ARVs in the South African setup, we need to be careful that 95% of our patients should remain on the first line. If you like, the first line is the best line. You want to be able to have a majority of your patients, so 95%. So if you're doing audits in your clinics, doing audits in your facilities, you want to be able to note how many patients are on first line. That's the first thing. Also, you want to be able to check the number of people that have viral load that's suppressed. That also is a very powerful indicator that one would like to be able to look at as part and parcel of those early warning signs. Movements to second line is determined by the viral load. So a viral load suppression that we want to see in most instances is less than 50. Any viral load above 50 says we must treat it as an emergency. You never switch only one drug in a failing regimen. You actually provide counseling, you provide the ABCD intervention, and if you do it properly, you can actually have quite a good number of success. There is an issue that perhaps I skipped around the issue of persistent low-level viremia. This is a patient who has a viral load falling between 50 and typically 999, and some people push it up to 1,000. If you have two readings and say a patient is on a TEE-based regimen and they need to be able to move on to to second line, if you have two readings of 3 months apart and they are on a TEE-based regimen, you can actually switch to TLD. This is the only time where you can actually switch a single drug in that particular case. If you have confirmed and you have done a proper assessment that this is a virological failure, you need to switch the complete regimen. And for DTG-based regimen and PI-based regimen, recent testing may be indicated for DTG on a case-by-case basis, but for PI-based regimens, if you demonstrate resistance, you can actually be able to switch, provided the patient has been on ART for more than 2 years.